My name is Rick Greene from the UVA medical class of 1970, and it's my great pleasure today to talk with Dr. Dick Lindsay for a program that we're doing for the Medical Alumni Association and highlighting our important faculty members who are emeritus at the University of Virginia. So Dick, thank you very much for being with us.
My pleasure.
Let me just sort of start out. I mean, you've been here since the 60s. What brought you to the University of Virginia? Why did you come here?
I came here because I grew up in upstate New York, where both my grandfather and dad were country doctors. My dad had taken ill. When I finished my internship in Buffalo, I went back and took over the practice. He recovered his health. It was a small town, and with two docs, there wasn't a lot of income coming in, so I said, what should I do? My professor in New York had been Dr. Crispell. Dr. Crispell left Virginia, went to New York, was professor of medicine where I went to medical school, and then he returned. So I called him and I said, gee, Dr. Crispell, I don't know what to do. He said, well, come down to Charleston and look around. I came down and a great giant hook at that point in time, and met Dr. John Owen, who you've interviewed, and Jim Respis and people like that. And they offered me an interim job, and then I started the residency. After that, went through the medical residency. That's how I got here.
So obviously there were things at the University of Virginia that have kept you here. You have an interesting background in you were acting chair in the Department of Family Medicine. You're obviously interested in geriatrics. That's been an area of expertise for you in the Department of Internal Medicine. Tell me a little about how family medicine developed here.
Well, since I had that experience I described to you with my dad and grandfather, I grew up in a family physician's house. They tapped me to establish the family medicine program. So for about 6 years, I worked at getting all kinds of things underway, eventually with recruiting residents and so forth. We had a place over here in the towers, and I even painted the walls. That was that kind of primitive operation we had. And it was difficult because this was a very specially oriented hospital. And this was the first time family medicine really penetrated that kind of environment. Came on the heels of a similar program at MCV, so there was a little bit of pressure from the state for both big medical schools to have family medicine. So we got started, and it was a very, very exciting time because, as I say, it was a really close-knit people who all had the same goal. We recruited a doctor from Abbey, Dr. Sam Miller, as my faculty cohort, and Sam Miller and myself really got the program started. Then they went out and recruited a very able guy from South Carolina, Lou Barnett, who became the subsequent chair. And I was looking around for what to do, and my professor of medicine was Ed Hook, and Ed said, we need something in aging. I said, oh, I don't know about that aging stuff. That doesn't sound very exciting to me. But since I was out of work at the time, I went home and thought about that, and I said, you know, that may not be a bad idea. And I was one of the first fellows in geriatric medicine at the National Institute on Aging, and really in on the ground floor of developing geriatrics across the country. So it became one of the best things I've ever done, and really enjoyed geriatrics here. It was exciting time. Both of them were exciting.
Tell me a little about what was the feeling of the internist as family medicine was being established?
Well, I think that was the real issue. Everybody here was used to having internal medicine on board, and a long established and superb training program in internal medicine. I think that the question was how they were going to mix pediatrics, OBGYN, the usual components that make up family medicine, with the training program. And I think they under Dr. Crispell's, I think, able leadership, they were able to bring together the pediatric department, OBGYN, and put together a very effective training program, embodying, I think, the best of several disciplines here at the university. And as a result, it became a very, very well-established and very good family medicine program. Fun.
What about geriatrics really interested you? Why did you gravitate toward that?
Well, I think it started when I took over my dad's practice. I suddenly was surrounded by people who were much older than I was. They were his patients. Including my grade school teacher, people like that would come in and say, who's this young man doing here? But that was the kind of thing that got me started, was I recognized that it was a lot like reading a good book. All of a sudden, there were people who, from my hometown, that knew a lot about the history of the place, and you could ask them questions which I don't remember much about, but they, at the point in time, knew a lot about the history of the place. And so I think that relationship I had with my dad's practice with a lot of older people really got me started thinking about it. Once we got the program going here, I think the same thing was true. There was a tremendous demand, and I think I came away from any encounter I ever had with an older person with just that same feeling that there's a lot more to them than just the medical issues that they had. And if you tap that, it made the practice just a lot of fun. And I found it a lot like reading a book, as I said. I spent as much time talking to them about whether they were a pilot in World War II in Britain or whether they had some cardiac problems, and it was fun.
Well, since I'm a surgeon, I have to ask you, was there a parallel process in the Department of Surgery to recognize geriatrics and what goes on with a geriatric patient here at UVA?
Well, that's an interesting point. Nationally, I became president of the American Geriatric Society somewhere along my career, and so I had a really opportunity to look at the national perspective of geriatrics. And geriatrics was really having a lot of difficulty nationally. With established programs, that kind of thing, was very difficult to come by. And I think one of the things that they've decided to do is they never can train enough geriatricians. That's what we set out to do, was to have a whole cadre of people. But in fact, the number of people going into geriatrics has decreased gradually. And so I think what they've done is change their modus operandi a little bit. What they're saying now is that you, the surgeon, urologist, ophthalmologist, everybody who interacts with an aging population ought to have a set of basic skills that relates to geriatric care. Rather than having just, I think you've got to have a cadre of people who are going to train other people in geriatrics, that kind of thing. But beyond that, we need to have a cadre of a broad-based group of specialties, all of whom have had some specific training in the care of a geriatric patient. And that's what the American Geriatric Society is about now. What they're doing is they're having an annual program where they bring residents from surgery, orthopedics, bring them up to Boston, and they give them a pretty intense course. These are chief residents, so they send them back to where they come from. And as chief residents, they can permeate their own program with a lot of what they learn as it relates to geriatrics. The goal being a well-trained cadre of diverse cadre of physicians, all specialties, having some much better knowledge base about geriatrics than they do currently.
I know geriatrics is now recognized by the ABMS, but tell me a little about the history of the board in geriatric medicine.
Well, it came about while I was actually president of the American Geriatric Society, and the whole thrust had been we had no recognition. There were fellowship programs, but there was no endpoint. There was no certificate. There was no specialty board. And so the idea was originally to make it a 3-year program, 3-year training program, following which you set for an exam and you're certified like any specialty board. And that's what they did. They've decreased it now back to 2 years rather than 3. And the same thing is true. You still have a fellowship program, which takes you 2 years, above and beyond training in internal medicine, psychiatry, disciplines like that. So you can come from different backgrounds, then have a 2-year fellowship in geriatrics, sit for the geriatric exam, and you'll be a psychiatrist with a certificate, special recognition in geriatrics.
Let me shift gears a little.
Yeah.
Tell me about Charlottesville. Tell me about being in Charlottesville, being at the university, other than being in medicine.
Well, I came in '61. It was a very different place, much smaller. I say the population was probably, university population was somewhere around 7,000 total. It was very much smaller. Class size was 64 in the medical school, so it was a very different environment. But what I learned when I first got here was it was a very friendly place. And the population that I found, both clinical population that I served, but more importantly, the colleagues and so forth, made it a delightful place to be. And there was a lot of camaraderie, there was a lot of mixing of both the students and the faculty. And I thrived in that environment. I thought this was the best place I'd ever been. And I remember my first evening here was under the tutelage of my then boss, Dr. James Respis. And he said, we're going to a cookout. I said, gee, great. And so I went there, and they had that big outdoor thing in the back of a truck, and they were cooking fried chicken. And I said, man, I come from the frozen north. This was really something. And there was a man standing beside me with kind of a plaid sport coat. And I introduced myself. I'm Dick Lindsay. I've come down from Old Forge, New York, and here I am. He said, I'm William Faulkner. So I called my father, who was a lifelong fan of William Faulkner, and I said, you'll never believe who I met tonight. It must have been 10 o'clock when I called him. My dad said, who's that? I said, William Faulkner. He said, oh, I don't believe that, he said. But that was the kind of place it was. It was an exciting place to be, and more importantly, I think the thing that made it special was the reputation of this place. Everywhere you went, medically, around the state, and you were at UVA, that was the key. People opened the door. It was a very, very well-respected institution medically, just an amazing place.
You know, you mentioned you were president of the American Geriatric Society. It seems to me, and again, I deal with medical students and young people going into surgery, it seems the feeling they have for organizational things is different than we had. How do you get a young person who's just in clinical medicine involved in organizational things, especially in your area?
I think you do it a couple of ways. The best way is through a mentor's attention to them, saying, you know, I'm going to the state society meeting today. I'd love to have you come along, or there's going to be a county medical society. Come on, we'll go out to county medical society. You'll meet some great people. It'll be a fun evening. And I think going with somebody like that, who knows other people, who can introduce them to say, yeah, this is Dick Lindsay, that kind of thing, made all the difference in the world, I think. So good mentoring programs, I think, is the secret to making people get interested in whatever the discipline is. And that's one of the problems today. I think that faculty have got to recognize that mentoring is a key part of what we do, but at the same time, they're under pressure to produce volume. And I think there's an excellent article in this week's JAMA about how to choose the next generation of medical students. And what it says in fact, they're looking for empathetic people, they're looking for people who can take good histories, and they're getting away from some of the scientific stuff that has been part and parcel of all of our training. But at the same time, we then finish them and plug them into a system where there's a volume of requirement, and 20 minutes is the time period, and the very heart and soul of geriatrics is being able to take somebody with 5 illnesses and talk to them about whether they flew in World War II. And you don't do that in 20 minutes. So I think there's going to have to be some striking changes within the system, and that's one of the things that I'm interested in and spend a lot of time doing, as you do too, probably.
You know, I know you were influenced a lot by your dad, you've told me. Was there anything else you wanted to do other than medicine?
Well, I grew up in a ski resort, and I was a very, very good skier. And I wanted to be an Olympic skier. I was about, I think, ranked 10th in Eastern United States. Then I had a terrible crash out west, broke my leg badly, and I never was very good after that. But if I had my options, whenever I watched the Olympics, I still think, God, I wish I'd been able to do that. So that was my, I guess, first choice. After that, I liked to teach, and I probably would have been a teacher.
Finally, let me ask you, you're emeritus. What does it mean to be emeritus? What are you doing?
Well, what I'm doing now is something that I got interested in through my geriatric career. One of the things that's true about care of the older population in the U.S. is 80% of the care is done by family members, not by you or I or nurses or trained people, but by family members. And in the process of caregiving, they often become sick as a result of being caregivers. So I put together something called the Institute for Innovations in Caregiving, and they renamed it, it's now called the Lindsay Institute for Innovation in Caregiving. We're focusing on ways to shore up the health of caregivers, to ensure that as long as they're healthy, then they can keep giving care. But the minute they break down, the individual they were caring for gets institutionalized, so it's very costly to the system. And we had just finished a very successful, interesting 2-day hackathon, 25.5 hours, 7 teams from colleges across Virginia, made up of nurses, social workers, engineers, all kinds of people. And they had 25.5 hours to design apps, products, websites that would assist a caregiver and help their health. And the first prize was a very substantive cash prize, but Virginia Tech team came away with first place. They designed a thing that allows people to, if you prescribe a diet, or I prescribe a diet to somebody and they go home, it allows them to look in the refrigerator and see what they've got. They can plug in what they've got there. If they don't have the right ingredients, you can get the recipes off the line. It tells them where the stores are, they can buy the product, what the price is, and it puts together a lot of helpful steps for somebody who's giving caregiving. So it was a very, very exciting, and more importantly, it now has got a population of kids who know what caregiving entails. Each of the teams also had a caregiver as part of the team, so they were there to balance their wild ideas with the practical sense of somebody who's doing caregiving every day. And that's kind of what I'm involved in, called the Lindsay Institute for Innovation in Caregiving. So.
What a wonderful program. Maybe next year a UVA group will win and not Virginia Tech.
Virginia had a good team, and they put together something having to do with alerting the docs and everybody to the levels of stress of people. It's a very, very good system, too. And there were a lot of really good programs came out of this thing, all kinds of things, everything from programs that allow them to access music that the individual liked, pictures for the family, and access to all the family members. The kids today have an amazing skill with electronic things. Usually one member of the team was an IT person, information technology, and so they came up in 25.5 hours, a finished product that's hard to believe. We had the same group, we mixed them with entrepreneurs, and so several of the programs have already been mixing with the entrepreneur and they're developing it commercially, so it'll be interesting to see it. They own the property from it, that'll be fun.
I can see how excited you are about
I was excited about it.
We've been talking with Dr. Dick Lindsay, Emeritus Professor at Internal Medicine, University of Virginia School of Medicine. Dick, it's a real pleasure to talk with you.
My pleasure to be here. Thanks for inviting me.
Thank you.
Yes, sir.